Dear colleagues, with great pleasure, I would like to greet you from behalf of the Armenia Eye Care Project, the Department of Ophthalmology of the Yerevan State Medical University, also Malayan Medical Center. I'm Ms. Kalashian. I'm the head of the project of the Armenia Eye Care Project. These seminars will be regular, and mostly we want them to appear once per month, and we will discuss a very narrow professional orientation in ophthalmology. Previously, we were talking about corneal diseases, and I think that it's very interesting and it was very helpful for our specialists. And today our discussion will be devoted to the neuro-ophthalmology, and this session will be led by our Armenian and American colleagues. So the topic is pseudotumors of orbital area, also conjunctival amyloid. We'll present peculiar cases from Armenia. Dr. Armenia Garakishisyan will be leading the session with her colleagues from Armenia. I think that I shouldn't present Dr. Garakishisyan. She's a candidate of medical sciences. Also, she's the neuro-ophthalmology and eye plastics department head, and she's also fellow of the Armenia Eye Care Project. And from the US, we have Mitra Gonzalez. So Dr. Gonzalez is from Rochester University. He's assistant professor of ophthalmology department. I think that the topic today will be very interesting today to all of you. And let me pass the chair to Dr. Armenia Garakishisyan. Thank you very much, and good evening, dear audience. Thank you very much for presenting us. And let us now talk in English.
Good morning, Dr. Gonzalez. Good morning, Dr. Hovhannisyan. How are you? We hope
good morning, very well.
It's
good to see all my good friends.
It's a great pleasure that you could find time to organize this interesting Zoom meeting. So our today's cases are two oculo-plastic cases. First case is going to be orbital sclerosing pseudotumor that will present second-year resident Mary Stepanyan. You must be remembering her. They have a chance to work with you in September during your first visit. And actually, we are planning to do the case presentation, and then after that to do discussion, because we have a lot of questions regarding that case to you. It's very interesting to know your opinion. And then we are planning that it will take half an hour. Then next half an hour, it will be second case discussion, case presentation that we'll do in second year resident Ani Israelian. And then we'll do next discussion. If it is okay, so we can start. Thank you very much. So the first case presentation, orbital sclerosing pseudotumor, presenting resident Mary Stepanyan. Please, Mary, thank you.
Hello, dear colleagues. It's a pleasure to be a part of this meeting. I want to thank AECP and our supervisor, Dr. Garakishisyan, for this opportunity. And I'm going to present the case of one of our patients who was eventually diagnosed with sclerosing orbital pseudotumor. So, a 52-year-old female presented to our hospital with complaints of gradual protrusion of the right cosmetic discomfort and tearing. According to the patient's relatives, the complaint started 4 years ago when a slight protrusion of the right eye was noticed, and she applied to another hospital where she was recommended to undergo laboratory examination to exclude Graves' disease. And the laboratory tests showed normal thyroid function. The patient also reported that she was diagnosed with paranoid schizophrenia in 2004 and was receiving psychiatric therapy. Therefore, she did not continue her examination for some time. So when she applied to our hospital, she had proptosis, a total subluxation of the right eyeball, and other symptoms present were chemosis, lag of thalamus, keratopathy, visual impairment, severe restriction of ocular movements, mild pain, and also there was a solid mass palpated in the upper eyelid region in the medial part. Her visual acuity in the right eye was determined as a hand motion and 20/30 in the left eye. Considering the patient's complaints, she was recommended to undergo a CT scan of the orbit, which revealed multinodular non-encapsulated mass of 52/40 millimeters in the right orbit, as it is seen in the picture, with uneven edges and distinct boundaries extending from the orbital apex along the medial wall of the orbit. There were no destructive changes in the bones as well as in the brain tissue. The eyeball was also not involved in the process. There were also some small nodules found in the left orbit, as it is shown in the picture, with the same CT features, and the eyeball and the bone were not involved in the process. So radiological impression was that this is suspected sclerosing orbital pseudotumor. Yet orbital lymphoma was not excluded. Based on the data of clinical examination, complaints, and CT scan features, we made a preliminary diagnosis of intraorbital neoplasm. And our plan was to perform an incisional biopsy, considering the facts that the eyeball was not involved and that the malignant origin of the mass was not excluded. We performed incisional biopsy, and the tissue was sent for HPE. And on the 7th day, we got the answer. The histologist noted that the growth was not malignant, and gave the preliminary diagnosis of pilomatrixoma, as the specimen contained foreign body type Jan cells, amorphous keratinized eosinophils, and basophilic cells. So this was a bit unexpected, both for us and for the histologist, because pilomatrixoma is known to originate from the matrix of the hair follicle, and it is a benign skin tumor. And in the case of our patient, the mass grew in the orbit and did not involve the skin of the eyelids. So due to this non-specific finding, we reviewed several case reports related to pilomatrixoma and found that sometimes, rarely, pilomatrixoma of the orbit can also occur. Furthermore, the symptoms of the pilomatrixoma were consistent with our patient's symptoms, as it is described as a painless, slow-growing, benign solid mass. And based on the fact that the patient's eye retained some vision and that we were dealing with a clearly non-malignant mass, our previous plan of exenteration was ruled out, and we decided to perform surgical debulking of the intraorbital mass. An anterior orbitotomy was performed. As you can see some pictures from our surgery, the mass is shown with white arrows. The mass was found in the orbit and was acutely separated within the boundaries of healthy tissues as deep as possible, up to the posterior 1/3 of the orbit. And the part of the mass which was located in this area in the orbital apex was not removed. But also some part of pathological tissue was removed from the upper and medial wall of the orbit. As a result, the eyeball became more mobile and was placed back into the orbit. We also performed medial and lateral incisions to provide lymph drainage on conjunctival chemosis. And we ended the surgery with medial, central, and lateral tarsorrhaphy with complete closure of palpebral fissure to protect the cornea. Here you can see the pictures of our patient after 1 week. So the removed tissues were sent for HPE, and after 1 week, we received an answer. which again excluded the malignant origin of the mass, but also excluded the diagnosis of pilomatrixoma. So histologists noted a presence of a large amount of fibrous tissue associated with lymphocytic infiltration and foreign body type giant cells. You can see in the first picture, it is shown with arrow, the fibrous tissue. And because the lymphocytic infiltration was quite large in some areas, it raised suspicion of an alternative diagnosis of a low-grade lymphoma. So the histopathologist mentioned that immunohistochemical examination is needed to clarify the diagnosis. So immunohistochemical examination was performed, and it ruled out possible sclerosing lymphoma and confirmed the diagnosis of sclerosing orbital pseudotumor. This is the first picture after 1 month after operation. So you can see the swelling as well as the proptosis had decreased, and the eyeball had somewhat better position in the orbit. So we decided to open the central tarsorrhaphy to make the binocular vision possible. And in the second picture, it's our patient with already removed central tarsorrhaphy. The visual acuity in the right eye was determined as a object detection, and the condition of the cornea also was improved. So sclerosing orbital pseudotumor is a rare subtype of inflammatory pseudotumor, which is poorly defined and is described in the literature in case reports only. It is a benign space-occupying orbital inflammation, which both radiologically and clinically mimics a malignant process or other inflammatory disease of the orbit. Therefore, it is difficult to diagnose and manage. And the sclerosing type behaves differently than the other types. So it grows more slowly, causes no pain or mild pain, and the presentation may be unilateral and bilateral. It is described characterized by scarring of the tissue, and occurs in all age groups with no gender predilection. It can also rarely extend into the sinuses, into brain tissue, and also in the other orbit, which was present in our case. So pathogenesis is unclear, yet underlying an autoimmune process is suggested. And as I mentioned earlier, the sclerosing type does not cause any pain, or pain is mild. So that's the main feature that differentiates it from the other types. And the most common symptoms observed are bulging of the eye and restriction of ocular muscles, also decrease in visual acuity in cases where the mass has an apical location. The diagnosis is obtained by exclusion, and HPE and CT scan are required. HPE is currently considered the gold standard for the diagnosing sclerosing orbital pseudotumor. It reveals large amount of fibrous tissue, and in cases where there is a possibility of alternative diagnosis, immunohistochemical examination is necessary. The main diagnoses that should be ruled out are Graves' disease, sclerosing orbital lymphoma, Wegener's granulomatosis, and metastatic tumors of the breast. So for treatment, there are no standard protocols because no large studies exist. And the sclerosing type, compared with other types, is less responsive to steroid therapy. So most cases suggest combination of steroid therapy and surgery. Others suggest combination of non-steroidal immunosuppressants with steroids. And of course, surgical debulking, which is crucial for the patients who have severely progressive and disabling clinical course, for example, apical mass with optic nerve compression. And also when the lesion is focal and is easily approachable. For radiotherapy, by far it showed poor results, and there was also one case where exenteration was performed, and it gave good results. So sclerosing orbital pseudotumor is a rare disorder. It is generally painless and slow-growing mass. The main thing that also differentiates this from the other types is that sclerosing type is less responsive to steroid therapy, and therefore combination therapy is suggested. Here you can see the pictures of our patient before the operation and after it, as well as in here. So our main concern is the future follow-up of this patient. So what follow-up would you suggest based on your experience? Would you recommend starting a steroid therapy here? Would you consider exenteration instead of surgical debulking? And what is the prognosis for the left eye? If it is the same as in the right eye, then what can be done to prevent the growth progression? Should we expect probably a recurrence? And do you recommend leaving the patient with therapy, and for how long? So thank you so much for attention.
Thank you, Mary, for this presentation. Dr. Gonzalez, please, it's great pleasure for us. Please, your opinion.
Yeah, of course. So number one, a very challenging case. Whenever we see an orbital mass, many different things come into mind. The imaging study certainly helps to guide us. I'm going to take a moment and I'm going to focus specifically on the non-specific idiopathic orbital inflammation, orbital pseudotumor. Number one, that's the term that I typically use, is non-specific idiopathic orbital inflammation. And then I'll use the term sclerosing type as a subtype identifier. And the reason why is I found that the language can sometimes be a little bit confusing. I've seen individuals with pseudotumor being treated with Diamox. And the reason why is there was confusion. This was a neurology treated patient, and the pseudotumor that they knew was in fact cerebral pseudotumor. And so they were treating it just because of a language confusion. So I typically try to be as clean and delineating as possible with the nomenclature. And so the nomenclature that I typically use for this is non-specific idiopathic orbital inflammation, sclerosing type. In the topic of non-specific idiopathic orbital inflammation, it's very interesting. It's a great historical lesson in medicine. If we return to its first descriptions coming out of the German literature, because much of medicine was being published in German at that time, the descriptions of what was then called, and I apologize for the confusion in language, orbital pseudotumor, was very much similar to the sclerosing type. It's characterized in these early descriptions as mass effect and painless. So it's fascinating because now whenever we think of non-specific orbital inflammation, one of the very common findings is that of pain. But in its original descriptions, not necessarily the case. And instead, the reason it was called orbital pseudotumor was because it resembled malignant neoplasms so similarly. And as we know, pain may be part of that presentation, but it's quite common for it not to be part of that presentation. So it's interesting how the disease ends up changing. You take that original description, and then we layer in new technologies, i.e. imaging studies. We're able to further define the disease with increasing frequency. So I wonder how many cases of orbital pseudotumor were in fact perhaps thyroid patients that were euthyroid. Moving further, we end up with CT scans. We're able to identify, wait a minute, the tendon is involved, this is going to be more likely a myositis, not a thyroid eye disease patient, pain with eye movement. So I bring this up because medicine is fascinating in its evolution, in its nomenclature, in how the disease is understood and described as a consequence of the technologies that are available to describe it. So because I think this captures those points well, I wanted to take some time to discuss that. Now, with regard to this particular patient, I certainly was suspicious with the diagnosis of the pilomatrixoma. Number one, it's unusual. And then number two, to think that it potentially hit both sides. Oh, anything is possible in medicine, as we know, but playing the odds, just thinking about it from the point of view, and I try to not be the person who is looking at it after all the information, but trying to put myself in the position of the provider making the decision. That diagnosis to me would have been a little bit suspicious. I would have been suspect of that. So I love the idea of going in, of taking more tissue, and then ultimately that I think really ends up shaping, getting us to the right place. One of my favorite quotes is, if you get on the wrong bus, every stop is the wrong stop. And so if we had been satisfied with this pilomatrixoma diagnosis, I think that we probably would have lost a lot of opportunity to protect the left eye. I'm not certain how much visual potential is in that right side. From the imaging configuration, there appeared to be a significant amount of stretch on the globe. And as a consequence, that suggests a significant amount of stretch on the nerve. And so the visual potential may be fundamentally limited in that eye. And so, of course, our targets change. Whenever we're in a situation and suddenly that eye loses its visual potential, that opens up more possibilities in terms of treatment options. And it very much shifts what it is that we're trying to accomplish. In situations not this, but let's say we were dealing with a malignancy there, we pivot from vision saving to life saving. And recognizing that pivot is occurring is really important because, we as eye surgeons, we're just so anchored and we've got to save vision. We've got to save that eye. And recognizing when that is no longer the appropriate target, I think is really wise. And it takes a lot of situational awareness to arrive in that moment because, again, we're just so trained, save the vision, save the eye. Even if it's just a little amount of vision, we might need it later on. But in those moments, it's important to recognize that we're pivoting from vision saving to a life saving type of scenario. Furthermore, there becomes a time when we're pivoting away from dealing with actual, for lack of a better word, treatment that's going to provide an improvement in visual function to a palliative type of treatment. How can we make the patient more comfortable? And so that's another pivot that oftentimes is difficult to make if we're solely focused on the protection of the eyeball, the protection of vision. So I'd be interested to know what the visual potential is in that eye. Whether or not, there's a significant APD, whether or not, the nerve is pale, and that certainly can shape what ends up happening next. But I'm actually going to ignore the elephant in the room, which is the right side, and say that left side is that's where I'm devoting a tremendous amount of my attention. And a lot of the management decisions that I'm going to suggest moving forward are going to be based off of that. So those lesions on the left side, I'm going to make the assumption that it is this sclerosing nonspecific orbital inflammation. It makes me somewhat concerned because one of the things that immediately came into my mind whenever I have bilateral hits on something is I'm thinking metastasis. Yes, it's possible that we could have the same process affecting both sides, something like thyroid eye disease. And yes, that can happen in nonspecific idiopathic orbital inflammation. That tends to be more common in the pediatric population. And interestingly, in that population, those folks end up presenting in a very toxic appearing state. They oftentimes look sick. So the presentation of pediatric nonspecific idiopathic orbital inflammation tends to be more likely bilateral than in their adult counterparts, and oftentimes is associated with systemic types of illness. They may have a fever, they may have some systemic discomfort, they appear sick. So I'm still a little bit worried about that left side. You know, we have a big biopsy here. So common things being common, my suspicion is that we're dealing with sclerosing, bilateral, nonspecific idiopathic orbital inflammation. But just as a cautionary note, I'm going to be following this and say, yes, I think that's 85, 90% likely. But if I see any sort of change, my threshold for biopsy is extremely low, extremely low. So I think that aggressive immunomodulating therapy is important. Of course, I think steroids, but I would also consider if there's access to rheumatology, bringing rheumatology on board for some of those steroid-sparing medications, because I do think that it's likely going to be something that is going to be prolonged. I think that it's going to be complicated, and the sooner you have a partner to help with that, I think the better. So that would be one of my considerations in terms of, if you will, the immediate next step. In some situations, we can see a profound response to the medical management, the immunomodulation. And as a consequence, I would not do anything with the tarsorphys until things were stabilized from a medical point of view. Stabilized, i.e., there's improvement, and perhaps the tarsorphys are not going to be required, or stabilized to the point that, well, we've plateaued in terms of improvement, and there's still significant exophthalmal, significant concern for exposure keratopathy. Because then, you know, if, again, based on the visual potential of the eye, based on how the other side is doing, we might be moving more to a palliative type of care for the right side. What would that look like? Potentially additional surgical debulking. That could also look like an orbital decompression to remove the bone to create more space. And those would be a couple of plays that might help to stabilize that right side and potentially avoid exoneration. Exoneration certainly is a possibility, but I would not necessarily rush to do that until I had optimized my medicine, potentially provide some palliative debulking, recognizing that there's potential comorbidity to the muscle, potentially to the nerve, decompression, again, to create some more volume. I would try that first before I went into exoneration. I sort of am thinking about it much like in the way that we manage optic nerve gliomas, those that are quite anterior, especially in a situation where the eye is lost, or I should say the vision is lost. Then when do I potentially do a surgery, and then what kind of surgery do I perform? It changes the targets. I'm not sure if I answered all of the questions, but I hope that I hit most of them. Did I miss any particulars?
So, Dr. Gonzalez, thank you very much. We think that all questions, what kind of steroid? Do you think IV steroids?
Yes. I would probably go with IV steroids in the beginning. I think that you're going to have the potential greatest opportunity for response. And I think that that's probably going to signal as to what you can expect moving forward. And yeah, I would go fairly high dose to see how this ends up responding.
Doses like we do it in Graves' disease, maybe the endocrinologist, or we need help.
Yes, I would. And I would go with that sort of protocol, this sort of UGOGO IV solumedrol protocol. see if that tempers this. Again, looking for a signal here. I'm looking for a response, and then again potentially including some of the steroid-sparing medications, because the hope is that you can sort of extinguish it, get the flames down with the steroids, and then layer in your immunomodulators that can keep things at bay.
Thank you very much. Dr. Hovhannisyan, do you want to say something regarding this first case?
Well, I want to save time to move on to the second one, because if it is as good as the first one, we want to spend some time on it. Just congratulate you, Mary. That was a really outstanding presentation, done in a very well and thoroughly, and it really set up for valuable discussion. And of course, Dr. Gonzalez did just an outstanding job drawing out the great teaching points that went well beyond the specifics of this kind of disease, and that I hope everyone listening was paying close attention, because many of the pearls he talked about, like being on the wrong bus and when we shift our thinking from sight-saving to life-saving, these are valuable things. Just one question, just to be specific. So what the primary treatment at this stage for the left eye will be the IV steroids, and maybe you can comment on any other sort of topical therapy just to preserve the cornea, particularly in the the good eye. Maybe Mithra, maybe Mary, you can talk about that.
Mary, please feel free.
Thank you so much, Dr. Hovhannisyan and Dr. Gonzalez. For this time, our patient is actually using eye drops. So it's Tobojex and artificial tears. Since the time we performed the operation, the last one, when we also opened the tarsorrhaphy, she's using eye drops for both eyes. I think we decided for her to use these eye drops for a very long time, until we can see our future follow-up, what's going to be. So for now, she's using artificial tears.
Actually, maybe we'll do another CT scan after 3 months to follow these lesions. At this point, actually, we don't need to do any biopsy on the left orbit, because tissues, masses are so deep, we don't want to do any damage to the healthy eye. That's why maybe we'll just follow the left eye to see how will the process go on. And thank you very much again. It was very interesting, your discussion. Actually, if you agree with me, maybe we can go to the next presentation. Next presentation will do our resident, Ani Israelian, second-year resident, and the topic is conjunctival amyloidosis. Thank you. Ani.
Hello, everyone. It's a very pleasure to meet you all today. First of all, I want to thank AECP and our supervisor, Dr. Hovhannisyan, for giving me such an opportunity to represent our very untypical case that we had 2 months ago. And so let's start. 64-year-old female presented to our hospital with a 27-year history of left ptosis. Her complaints for the left eye were ptosis, foreign body sensation while blinking, and blurry vision. The patient said that there were no personal or family history of any systemic disease, and our patient added that she used alcohol daily. On our ocular examination, her visual acuity for right eye was 0.05 and for left eye 0.07. Intraocular pressure were normal. Pulmonary visual high during primary gaze for the right eye was 10 millimeters, and for the left eye was 3 millimeters. Margin reflex distance 1 was minus 2 millimeters. Levator function was normal, 15 millimeters, and ocular movements were full. During slit lamp examination, revealed a bilateral cataract and yellowish, irregular yellowish mass on the surfaces of her upper and lower eyelids of conjunctiva, fornix conjunctiva, which not tended to bleed easily. Eversion of the right eyelid showed no abnormalities. Our preliminary diagnosis was bilateral cataract, and for the left eye, aponeurotic ptosis and conjunctival lymphoma with question because of the color, the mass. As the levator function was normal, 15 millimeters, so we performed LPS reattachment surgery. During surgery, we put one central stitch instead of three because there was overcorrection of the upper eyelid. Besides the surgery, we also performed incisional biopsy, about 10 millimeters of the yellowish masses. Here we see 1 week after operation, a photo of our patient. We see underfraction of the upper eyelid, like there's no surgical intervention was done. The call from a pathologist. He did hematoxylin eosin stain and revealed amorphous deposits positive for hematoxylin eosin. And the main thing was that there were no tumor cells or so many lymphocytes as we can see during lymphoma. After that hematoxylin eosin stain, he also did Congo red stain, and that material, amorphous deposits under polarized lamp, revealed green birefringence, characteristic of amyloid depositions. To rule out systemic amyloidosis, we referred our patient to the rheumatologist. A rheumatologist did some checked her blood, was done some genetic analysis, and was revealed pathogenic heterozygous mutation in the MEFV gene. And her blood example was sent to Germany for later examination. In Germany was done test that revealed high amount of serum amyloid A. After that was done abdominal sonography. Sonography showed us some pathological transformations in liver, but as we said, our patient used alcohol daily, and we can't say the main reason of these transformations is amyloidosis or alcohol. And sonography showed no abnormalities in kidney or spleen. Our final diagnosis is a familiar Mediterranean fever with only complication of conjunctival amyloidosis. Familiar Mediterranean fever is autoinflammatory disorder, usually considered autosomal recessive disease, predominantly affects Mediterranean people, including Armenians, and clinical consequence, systemic amyloidosis. Typical symptoms of fever, abdominal pain, chest pain, painful swollen joints, and myalgia. In our 25-year history of our department, we never had such a case as conjunctival amyloidosis, and so we perform researches in PubMed. Let me introduce some typical pictures of conjunctival amyloidosis. Symptoms are pain, ptosis, foreign body sensation, as our patient had. Patients with periocular or orbital amyloidosis, proptosis, globe displacement, diplopia, and limited ocular motility. Masses are salmon-colored or yellow-pink colored, and they are tended to bleed easily. Management for localized conjunctival amyloidosis, use of artificial tears, excision, liquid external beam therapy. For patients with systemic manifestations, stem cell transplant, chemotherapy, and steroids. Standard treatment is the surgical debulking, but sometimes complete excision is not always possible, so the disease may recur. A feature of our case are that mass is brightly yellowish and not tended to bleed. We have no clinic of familiar Mediterranean fever, for example, pain or fever. No other organs were involved. Now we present secondary conjunctival amyloidosis at systemic involvements. Our patient now is under control of rheumatologist and taking colchicine 0.5 milligram daily. And our questions, have you ever came across with such a case in your practice? How will you recommend us to continue this case? Will you recommend to do excision of the amyloid masses? And what about ptosis correction? Because our patient is very interested of ptosis correction. Thank you.
Thank you very much, Ani. Dr. Gonzalez, what was interesting, this case that we have never seen this kind of masses. First thing that I saw these yellowish masses is this lymphoma, but it was so far from Salmon patch that we used to see. And it was not bleeding. That was the second thing that we were thinking that it is not possible that it can be amyloidosis. And first answer that this is amyloidosis, that was from histopathologist who told us that they are not tumor cells. This is something gathered and he is going to do test for amyloidosis. And he did call back again to us that this is amyloidosis. And I was telling him that it is so unusual. It must be bleeding easily. It was bright yellow. It is impossible. Clinically, it is so impossible. And the next thing that she was telling that no fever, no any systemic, any history of Mediterranean fever. So it was very strange for us. Next thing, that what to do with these masses, because on the table during the levator reattachment, she was giving a large overcorrection that I was to cut the medial and lateral sutures and left on the central one. But next day, so bad undercorrection, and maybe these masses are the reason that the eyelid is going down. But is it possible to remove these masses? If I remove, will it bring to severe scarring changes in the conjunctiva that will make worse the situation? So a lot of questions. Thank you very much. Please, we are listening to you.
Yeah, right. So, again, great thinking throughout the entire process. Something unusual. What is it that we're dealing with? Common things are common, but at the same time, the exotic exists, and being mindful of that from the get-go, I think, is just so wise. A number of, I think, of good broad talking points here. So with regard to the type of incision, or I should say the type of biopsy that we perform. So, we see a lesion. In some situations, it is possible to remove it in its entirety, an excisional biopsy. And that's often nice. Sometimes the lesion is much more diffuse, and it's not possible to remove it all. And so one of the sort of techniques that I've found to be very helpful is the temptation maybe to go directly into the middle of the lesion, but sometimes that actually is just entirely abnormal, and it may represent a very advanced state of the disease, which could be just simply necrosis. And I'm referring not just to this lesion, but to pretty much all biopsy scenarios. And so oftentimes when I take a biopsy, again, this is not just for this case, but biopsy cases overall, I want to try to give my pathologist every opportunity to see the transformation between normal to diseased tissue. So oftentimes my incisional biopsy will be more in the perimeter than in the central portion of the lesion, so that my pathologist can get the transition and not just see the terminal process. So incisional biopsy, and where I typically like to target that. If I have the opportunity to do an excisional biopsy and it's not going to cause significant morbidity, then of course that's ideal, but it's not always the case, as we know. When I do the biopsy, I'm trying to anticipate what the biopsy might show. And there are some very common things that end up showing up around the orbit. Of course, neoplasm. And then within the neoplastic space, not uncommonly lymphoma or lymphoproliferative, and also, of course, inflammatory, and then, of course, infectious. So early in my career, I probably was a little bit more, oh yeah, I know what this is, and I'm only going to send precisely what I thought was going to be helpful. Having been fooled enough, I now typically send, taking into account that this lesion, which is unknown to me, could be any of those things. Why? Well, there were a couple of cases very early in my career where I thought it was going to be, for instance, a lymphoma. In actuality, it came back as a sarcoidosis. And because I had not sent the appropriate micrology, the rheumatologists were unwilling to get on board with providing some of those non-steroid sparing medications, steroid-sparing medications. So that was very instructive to me. And so now, just as a matter of protocol within my OR, when I do these types of orbital biopsies, I make sure that I'm sending for permanent. I'm also sending for a lymphoma protocol. I'm also sending for micrology. Just as again, just trying to hopefully avoid the need for repeat biopsies in the future, because that's what I ended up having to do on that patient I just described. I had to go back in to get micrology to send so that the rheumatologist felt comfortable, because rheumatologist says, well, this could be some sort of atypical, I don't want to start immunosuppression conversation. Okay. So that's number one. With regard to this particular patient now, I love the approach. I love the approach in terms of getting the biopsy. And I was a little bit confused. Did the blepharotosis repair take place at the same time as the biopsy, or were those broken up?
No, it was done simultaneously. After doing the reattachment, I took 10 millimeter of tissue the same time and sent it to HP. Understood.
So one of the things that I would certainly consider is I would see what kind of response, what kind of response to treatment we're getting from the medical management, and whether or not that is going to end up changing the lesion, changing the eyelid position. Currently, and I couldn't tell this from the pictures, are there any mass effect lesions? Are there any lesions that are weighing on the lid? Any lesions that are providing bulk that are potentially interfering with the lid's positioning?
We can go back. Will you please turn on the photo of the slide? Actually, these masses are only from the conjunctival surface. When I was doing the surgery, the muscle and everything was looking normal, no any yellowish deposits. So the only thing that we could find these masses, that is lower fornix and upper fornix of the left eye. And
in the upper fornix, is it bulky? Is there anything that you potentially could further remove?
Actually, from the skin side, as it is seen, from the skin side, nothing that is bulking, but from the conjunctival side, so how do you think? Do you think we can remove all these masses?
I do think that probably removing some of that would be helpful. I do. And I would do it in a staged way. I would remove some of the mass, maybe 3 to 4 months later, reassess the lid position, make sure that I had a stable lid position for maybe 4-6 months after surgery. Once I have a stable lid position, then I would consider potentially doing a revision of the blepharotosis. And I would probably do, again, much as you have done, an external levator advancement in order to sort of minimize the amount of if you will, trauma to the fornix area.
So actually, he will suggest, first of all, to remove these masses, wait several months, and then do again ptosis correction. Am I right?
Yes, that's exactly what I would propose. You know, the masses themselves can cause some irritation, and I've been involved in a couple of cases, one of which was a pediatric scenario. The child was coming in with almost looked like ocular guarding. They had a follicular reaction. And so, yes, they did have ptosis, but they had ptosis for a very specific reason, namely that they had this follicular reaction. It turns out that they had molluscum contagiosum. And ultimately, the lesion identified itself. We treated the lesion and the ptosis corrected, and we didn't have to do anything to correct the ptosis. You know, one of the little things that I would consider doing to sort of test that hypothesis is just simply putting in some tetracaine or some proparacaine and to see if the blepharoptosis improves. If it is in fact from irritation and there is, if you will, ocular guarding, then potentially debulking that mass may end up improving the blepharoptosis and give you again a different target.
Dr. Gonzalez, and how do you think if we remove all these masses, will it bring to severe scarring process?
You know,
shortening of the
I would not necessarily go in thinking that I could remove all of it. I would remove as much as I could, especially that which was going to impact the cornea. The way that I would sort of think about this is what I'm really trying to do is to reduce the irritation from the mass effect, not necessarily to clear all of it. And you know, if there is concern for shortening of the fornix, I would consider putting in some sutures to help stabilize it, a symblepharon ring. Or some sort of conformer that can help to ensure that it doesn't form a symblepharon. But the goal from a surgical point of view, in my mind here, is to help minimize the amount of irritation that the mass effect on the upper lid is potentially creating. And again, the thing that I would do to sort of test that hypothesis would just simply put a little tetracaine in to see if that improves the lid position. That could potentially temper how much you would want to remove.
Okay, actually, the patient is living far from Yerevan. She's from far regions of Armenia, and we are waiting her this month to see her back because 2 months is back, and we are keeping follow up her only by phone calls and taking her photos only by emails and this kind of connection. So, but the patient will be back to the clinic this month, and we will do the examination that you told us. We'll put a tetracaine to see how is changing the position of the upper eyelid, and then so you think that partially these masses can be removed, the part that is causing irritations, the cornea, and to see what kind of result about the position of the upper eyelid, yes?
Correct, exactly.
And what is interesting, she's telling us that she's taking colchicine and she's doing better. Of course, I'm not sure because the rheumatologist is telling us that the colchicine cannot take away these masses. It will prevent the further involvement of the kidneys, and it will be preserved for her life. And but she is telling us that she is better and these masses are less. So actually, when she will be back and will be able to avert her upper eyelid and see what is going on during these 2 months, is how are changed the things. I'm more than sure that nothing is less there, but she's telling us that she is better with colchicine. What do you think about this?
I hope so.
Thank you. Will you please turn on the cameras? Dr. Hovhannisyan, please, your opinion.
Well, again, a really excellent presentation. Ani, congratulations. And congratulations to you too, Armina, on preparing these residents so well and choosing such great cases to present here, because the teaching goes well beyond conjunctival amyloidosis and nonspecific orbital inflammation. Here's one other tip, I think, that a lot of us who are not in oculoplastics are on this conference and watching, and I think there's a great teaching point to be made. And throughout my career, I've probably saved the lives of 4 or 5 of my patients by doing one simple thing during every exam. When you examine a patient, whether you're doing it for, checking a pressure, whether the primary reason for their visit is a pressure check or a cataract check, always have the patient look up and examine the conjunctiva. Always have the patient look down and lift the upper lid and examine the conjunctiva, because you will find disease, sarcoidosis, amyloid in some cases, and of course lymphoma occasionally is found through that simple examination that you will miss entirely if you're just looking through the palpebral aperture and seeing what presents. So it should be part of every eye exam. Anyway, congratulations on great teaching in this conference, and thank you to Mithra Gonzalez for being our esteemed professor who has given so much to this department.
Glad to be
Thank you very much. Thank you very much. It was 1 hour, but it flies just so quickly, and it was great for us. Thank you very much. Your comments were so interesting for us. We were waiting for your opinions and for your thoughts. So it is, again, one more time, it's great pleasure to see you, to be able to present you and to get your answers. Also, Dr. Hovhannisyan, thank you very much for taking part during this Zoom meeting. It's a great pleasure. We hope that after several months, we will have another chance again to see you and to do discussion of another complicated cases. Thank you very much.
Thank you.
Thank you very much.
Take care. Bye.
Thanks, everyone.
Bye.